Hello. Thank you to Sages and the moderators for the invitation to participate in this session. My name is Arielle Perez, and I'm going to be reviewing absorbable synthetic mesh. What does the evidence say? I have no disclosures. The cure for hernias continues to elude us, and we continue to have patients who present in our surgery clinics with abdominal bulges and hernias such as these. But this type of patient is one that we fear the most. In the 2000 New England Journal of Medicine article, Lewandike et al. Published preliminary findings of a randomized control trial comparing suture repair to mesh repair. After 3 years, they found that mesh use reduced the incidence of hernia recurrence from 43% to 24%, regardless of the size of the hernia. In the subsequent 2004 Annals of Surgery article, Berger, Lewandike, and colleagues published their long-term results of the same study, demonstrating a 10-year cumulative rate of recurrence going from 63% for suture repair down to 32% for mesh repair. These, along with multiple other studies, have solidified the notion that mesh repair reduces the incidence of hernia recurrence by almost half. In the realm of mesh, there are three main categories: permanent synthetic, biologic, and absorbable synthetic. Dr. Warren has just gone over permanent synthetic mesh. Why don't we always use permanent synthetic mesh? It's cheap, easy to use, and there's good evidence for its use in hernia repair. But we all worry about seeing patients with wounds looking like this. Mesh complications have been well documented, both short-term, such as surgical site infections, seromas, hematomas, and bowel adhesions, and long-term, such as mesh extrusion, chronic draining sinuses, and mesh erosion, leading to an enterocutaneous fistula, have forced surgeons to seek alternative methods of hernia repair other than permanent synthetic mesh. In 2010, the Ventral Hernia Working Group was formed to better identify the risk of developing a surgical site occurrence or surgical site infection on patient wound risk factor characteristics. It should be acknowledged that this study was funded by a biologic mesh manufacturer. They have proposed a 4-level grading system where patient factors, wound factors, and choice of implant were deemed to be the most important determinants for surgical site occurrence. Based on their work, the authors provided recommendations on mesh use based on the grade of the hernia repair, advocating the consideration of biologic mesh use in settings where risk of surgical site occurrence was increased for Ventral Hernia Working Group grades 2, 3, and 4. In 2012, the 4-level system was modified into a 3-level grading system as a means of predicting surgical site occurrences rather than as a means for mesh recommendation. Biologic mesh was introduced in the 1990s as an alternative to permanent synthetic mesh. Potential benefits of biologic mesh were its theoretical reduction of infection and long-term mesh complications due to the material being resistant to infection and not requiring removal, antimicrobial activity seen in animal models, neovascularization assisting with bacterial clearance, and better resistance to bowel adhesions. The drawbacks to its adoption were the high cost of the material, its poor handling ability making it difficult to use, and lack of long-term outcome results. As more biologic mesh has been used and time has passed for evaluation, studies have shown that surgical site occurrences and hernia recurrence rates are still no better with biologic mesh. Thus, absorbable synthetic mesh has been marketed as a potential mesh alternative to biologic and synthetic meshes, based on its theoretical lower risk of infection and fistulization compared to permanent synthetic mesh. Absorbable synthetic mesh is more expensive than permanent synthetic mesh, but it is cheaper than biologic mesh. So what do the studies show to support its use? First, let's define what is an absorbable synthetic mesh. In the literature, absorbable synthetic mesh goes by many different names: biosynthetic, absorbable and bioabsorbable, resorbable and bioresorbable, degradable and biodegradable. Absorbable synthetic meshes are composed of resorbable polymers that gradually degrade over time. They provide a temporary scaffold for tissue ingrowth and neovascularization, allowing for remodeling of the abdominal wall with the patient's native tissues. It's theorized to reduce chronic infection given the lack of permanent material, and as such are marketed by manufacturers as cost-effective alternative to biologic meshes. There are 4 absorbable synthetic meshes on the market today. For ease and clarity throughout the remainder of this presentation, I will be referring to these 4 meshes by their commercial names. In the instructions for use, it should be noted that none of these absorbable synthetic meshes are FDA approved for use in contaminated settings. Absorbable synthetic meshes are composed of polyglycolic acid, polylactic acid, trimethyl carbonate, or poly-4-hydroxybutyrate. Changes in the ratio of these polymers results in various absorption profiles. Ethicon manufactures Vicryl mesh. It is composed of polygalactin 910, a copolymer of polyglycolic acid and polylactic acid. It is the quickest absorbing mesh of all 4, losing 75% of its strength in 14 days and being fully resorbed in 2 to 3 months. WL Gore manufactures Gore Bio-A, which is composed of a copolymer of polyglycolic acid and trimethylene carbonate. The majority of its strength is lost at 3 to 4 months, and the material is fully resorbed in 6 to 7 months. Bard manufactures Phasix and its barrier-coated sibling Phasix ST. It is composed of a monofilament poly-4-hydroxybutyrate polymer produced by E. coli bacteria through transgenic fermentation techniques. The majority of its strength is lost at 4 to 8 months, and the material is fully resorbed in 12 to 18 months. Nova Scientific manufactures Tiger Matrix. This mesh is composed of 2 different fibers with different degradation times. There is a fast-absorbing fiber composed of polyglycolic acid, polylactic acid, and trimethylene carbonate, which comprises 40% of the mesh content. And there is a slower absorbing fiber composed of polylactic acid and trimethylene carbonate, which comprises 60% of the mesh content. The majority of the strength of the fast-absorbing fibers is lost at 14 days, while the slow-absorbing fibers lose the majority of its strength in 8 to 9 months. The fast-absorbing fibers are completely resorbed at 4 months, while the slow-absorbing fibers are resorbed in 36 months. Based on the resorption times and presence of strength, only 3 of the absorbable synthetic meshes can be considered long-term and suitable for hernia repair. In order to evaluate the role, if any, absorbable synthetic mesh has for the repair in hernias, we should begin with evaluating the preclinical data. In the systematic review by Perez et al., a literature search of in 2017 for absorbable synthetic mesh in experimental studies turned up only 12 published articles evaluating absorbable synthetic mesh. 8 of the 12 studies evaluated Gore Bio-A mesh, 2 of the 12 studies evaluated Tiger Matrix, and 4 of the 12 studies evaluated Phasix mesh. The heterogeneity of these studies makes it difficult to compare and contrast absorbable synthetic meshes. Evaluated outcomes were not standardized among the studies. Some looked at tissue remodeling and inflammation histology. Some evaluated tensile strength, some evaluated adhesions, and some evaluated recurrence. The models were different, comparison meshes were different, the defect size and type were different, and surgical techniques were different. Only 1 study evaluated mesh in a contaminated setting, but even in this study with inoculation of bacteria, evaluation was performed only after 7 days and not in a hernia model. Only 4 studies had a follow-up of 1 year or longer. Caution should be taken when evaluating these studies, as there is potential conflict of interest in funding for these studies by key stakeholders and manufacturers. However, through these experimental studies, results support the resorption times and longevity of strength that have been described by the manufacturer. Phasix appears to induce the least inflammatory response. All 3 induce collagen deposition. Phasix appears to clear infection better than Bio-A and appears to lose less strength in the process. Contamination with Tiger Matrix has not been evaluated in published studies. Biomechanical properties appear to provide an initial increase in strength, but over time, strength may decrease to similar strength of native abdominal wall muscles. Bio-A and Tiger Matrix have less adhesions than permanent synthetic mesh, but more than biologic. Adhesions of Phasix mesh were not evaluated. In regards to clinical outcomes data, to date, there have been no randomized controlled trials evaluating use of absorbable synthetic mesh on hernia repair. There have been 2 clinical studies evaluating the use of absorbable mesh for the prophylaxis of a hernia during laparotomy closure, and there have also been 2 clinical studies evaluating Tiger Matrix for inguinal hernia repair, which were published by the same author. In 2 small prospective cohort studies, Ruiz-Jacobson et al. Evaluated Tiger Matrix in the use of primary inguinal hernia repair using Lichtenstein technique, as well as in a laparoscopic TEP repair. After 3-year follow-up from Lichtenstein repair, the authors found that there was a 23% recurrence rate with absorbable synthetic mesh, with 16% complaining of chronic pain and 10% with complaints of mesh sensation. After 1-year follow-up from a TEP inguinal hernia repair with Tiger Matrix, the authors found there was a 3% recurrence rate with absorbable synthetic mesh and no complaints of chronic pain. From 2016 to 2020, there have been only 9 clinical studies evaluating absorbable synthetic mesh for ventral hernia repair. Only 1 of the 9 studies had no reported conflict of interest or support from the mesh manufacturer being studied. None of them have been randomized clinical control trials. 4 have been retrospective studies, 4 have been prospective studies, and 1 was a continuous quality improvement study. The baseline operation, patient population, and wound class were variable with each study. Only 2 studies had the entire patient population with some level of surgical contamination. Only 4 had a complete study population of high-risk patients for surgical site occurrence based on ventral hernia working group grade. There was 1 study that evaluated absorbable synthetic mesh as a comparison group against polypropylene. 2 evaluated Gore Bio-A mesh. 1 studied Tiger Matrix. and 5 evaluated Phasix mesh. Mean follow-up time ranged from 30 days to 3.5 years, and the outcomes evaluated vary from study to study. Surgical site occurrences were under 28% for all studies. Surgical site infection rates were under 10% in all studies, except for the only 2 studies in which the entire study population had some level of surgical contamination. Recurrence rates were under 20% in all studies, except for 1 study by Cho et al. Evaluating retrorectus versus intraperitoneal placement of bio-A mesh in open complex ventral hernia repairs, where they found that intraperitoneal bio-A mesh placement had a significantly higher recurrence rate of 42.9% compared to 8.1% in retrorectus repairs. Similar to the preclinical studies, the heterogeneity amongst the clinical studies makes it difficult to compare and contrast absorbable synthetic meshes. Based on Dr. Warren's information, we can assume permanent synthetic mesh is the most reasonable choice for a clean, low-risk hernia repair in terms of outcome and cost. As such, there are only 4 of the 9 studies with the entire patient population having baseline characteristics in which an alternative to permanent synthetic mesh may be useful. In the small retrospective review by Pakula and Skinner of just 20 open ventral hernia repairs with retromuscular Phasix mesh in high-risk patients with ventral hernia working group grade 2 or 3, the authors found a low rate of complications without any recurrences after a mean follow-up of 21 months. In 2018, Roth and colleagues published the results of a BARD-sponsored study of Phasix mesh, evaluating its use in clean open ventral hernia repairs. All patients had a higher risk of surgical site occurrence with a ventral hernia working group grade of 2 or 3. All 120 repairs had mesh placed in either the retrorectus or onlay position. After 18 months, which should be noted is just when Phasix is supposed to be almost completely resorbed, postoperative results showed a surgical site infection rate and recurrence rate of 9%. The complex open bioabsorbable reconstruction of the abdominal wall, or COBRA study evaluating Gore bio-A mesh, was a multi-center prospective longitudinal study evaluating the use of Gore bio-A mesh by Rosen and colleagues. In a total of 104 clean contaminated ventral hernias, over 2/3 of the patients required a component separation, with 90% having mesh placed in the retrorectus space and 10% in the intraperitoneal space. The mean hernia size was 137 centimeters squared, and the mean width was 9 centimeters. After 2 years, 84% of the patients completed follow-up. Results of the COBRA trial demonstrated that absorbable synthetic mesh used in contaminated ventral hernia repairs had a surgical site event rate of 28%, surgical site infection rate of 18%, and hernia recurrence rate of 17%. Now, when we compare these results to the RICH study, evaluating biologic mesh in contaminated fields, we find that outcomes in surgical site events, surgical site infections, and hernia recurrence were all superior in the COBRA study using Gore bio-A mesh. Even when accounting for just the repairs with fascial closure from the RICH trial, the absorbable synthetic mesh appears superior. A true comparison between the RICH study and the COBRA study is somewhat difficult, however, as the patient populations were somewhat different. The RICH study had a higher level of contamination. Lower rates of fascial closure were done in the RICH study. Higher rates of intraperitoneal mesh were done in the RICH study, and larger hernia sizes were seen in the RICH study. In the 2018 review by Petro and Rosen in Plastic and Reconstructive Surgery, comparison of the COBRA, RICH, and Roth studies are made against the results of a 2013 multi-institutional study by Carbonell and colleagues, evaluating clean contaminated and contaminated open ventral hernia repairs with light and mid-weight polypropylene mesh in a retromuscular position with a mean follow-up time of 11 months. With similar follow-up times, it appeared that recurrence rates of Phasix may be comparable to permanent synthetic mesh. Recurrence rates of bio-A and biologic were higher, but it should be remembered that these studies had longer follow-up times. 30-day surgical site infections appear to be superior in the Roth trial with Phasix mesh, but again, these cases were all clean cases as compared to the clean contaminated cases. Rather, it should be noted that amongst cases with contamination, permanent synthetic mesh did the best. Surgical site occurrences requiring procedural intervention were fairly low with all meshes in all the trials. Removal of mesh was only required with permanent synthetic mesh and not with any of the of the absorbable synthetic mesh and biologic mesh cases. In a retrospective review by Sahu and colleagues of open ventral hernia repairs from the AHSQC, or what is now referred to as the Abdominal Core Health Quality Collaborative, 30-day wound events in all elective clean contaminated and contaminated cases using absorbable synthetic mesh and uncoated polypropylene were compared using a 1-to-3 propensity matching. Less than 10% of the cases were repaired with an absorbable synthetic mesh. And over half of those were used in low-risk clean cases. 58 clean contaminated and contaminated cases using absorbable synthetic mesh were matched to 174 permanent synthetic cases. Only after 30 days, repairs with absorbable synthetic mesh had a statistically significant higher rate of surgical site infection, surgical site occurrence requiring procedural intervention, and unplanned reoperations. The BioMesh Study Group, a European working group of specialized surgeons, published their consensus findings in 2018 on biologic and biosynthetic meshes and concluded that biologic and bioabsorbable meshes do not provide a superior alternative to synthetic meshes, that biologic and biosynthetic mesh use in contaminated conditions is no better than synthetic mesh used under the same conditions. Biologic and bioabsorbable mesh should not be used in a bridging situation, that there is no clear advantage for biologic or bioabsorbable mesh in inguinal hernia repair, and that there is an urgent need for high standard comparative studies in well-defined patient populations. In conclusion, there are 4 absorbable synthetic meshes on the market with various lengths of performance once implanted. No clinical randomized control trials are available on absorbable synthetic meshes to date. Due to the heterogeneity of available studies, conclusions on absorbable synthetic mesh are hard to draw. Current evidence does not show superiority of absorbable synthetic mesh to permanent synthetic mesh. Long-term comparative studies in patient groups where an alternative synthetic mesh is warranted, such as contaminated cases and high-risk patients, is necessary. Thank you.